Her areas of interest include evidence-based clinical transfusion practice, hematopoietic stem cell transplant, and immune-based cellular therapies and therapeutic apheresis. She has many administrative duties, but she also devotes a considerable portion of her time to Harvard Medical School teaching activities and participation in national and international organizations within her areas of expertise. She graduated from the University of Cincinnati College of Medicine and did her residency in pathology at Beth Israel Hospital and Harvard Medical School in Boston. And she's going to be talking to us about managing transfusion support of the stem cell transplant patient. Thank you.
So thank you, and I want to thank the organizers of this afternoon's meeting for inviting me to come. I am missing our third snowstorm by being here, so I really am drinking in all the warm weather here, so thank you. So I was asked to talk about transfusion management in stem cell patients, but that is a huge topic for a very short period of time, and so I elected to talk specifically about platelet transfusion management for this patient population. And just to go through the goals, what I want to do is just set the framework with regard to how much transfusion activity there is out there, both on the national level as well as local to my hospital, and hopefully you can frame the transfusion activity for your own institution within that background. I also would like to review with you platelet transfusion risks and mitigation strategies against those risks, and then review with you the etiology and management of HLA-mediated refractoriness. And Lisa set me up nicely for this as well, so I'll be able to go a little quickly through some of the testing. So this is a snapshot from a publication by AHRQ that looked at data in 2011, and among many of the much of the information that was presented, they really zoned in on the fact that blood transfusion was one of the most common procedures performed during hospitalizations in that particular year. And in fact, the rate had more than doubled since 1997. So there's a lot of transfusion activity going on. And looking at the data in a different way, this is data that's collected through surveys that some of your institutions, I'm sure, participated in, and analyzed by HHS and AABB, which is the Professional Organization for Blood Banks. And what you can see is that over the course of time, this is units in millions over years, there was a gradual increase in the amount of red cell transfusion, and more recently we actually are starting to bend the curve. But still, it's pretty brisk in terms of activity, with over 12 million units transfused a year in 2011, and subsequent data will be coming out shortly. With respect to platelets, what you can see, it's a pretty steady incline, not real steep, but it isn't bending, if you will, yet, and unlikely to bend going forward, because we are managing much sicker patients across the board, and certainly with the intensity within the bone marrow transplant setting, patients that have prolonged naders. So bringing it back to my own institution, Beth Israel Deaconess Medical Center, just some fun stats and facts. We're a moderately sized hospital, tertiary/quaternary, and full service. We have a level 1 trauma, level 3 nursery, and about 41,000 discharges a year. And we have an active transplant program. The numbers aren't high, but we have a lot of breadth, if you will. We transplant both autologous products as well as allogeneic products, including umbilical cord transplants. And in terms of looking at our transfusion activity, what you can see similar to the national data is that our red cell transfusion activity has declined over the years. And this is inpatient and outpatient activity. And you can see it in calendar year 2013, we transfused about 15,000 red cells. And specifically looking at platelets, at about 4,500 platelets during calendar year 2013. Breaking it further down to adult inpatient transfusion activity by service, and I share this data with both our surgery service, our medical service, as well as the HEMONC service, just so that they have an idea about how they compare to others and how they're doing just within themselves. And what you can see with respect to our HEMONC population, of the inpatient transfusion volume, 14,000 red cells, about 21% of those red cells went to our HEMONC population. And this is all comers, both the transplant as well as solid tumor patients that are admitted to the service. Platelets, on the other hand, 3,100 roughly platelets inpatient. You can see almost half of our platelet transfusions went to the HEMONC service, and I must say a significant portion of these products went to our stem cell transplant patients. And I wanted to also frame this transfusion activity in terms of a broader data set, and this is data from Saul et al. Out of University of Minnesota. And what they did was a review of 229 consecutive bone marrow transplant patients looking at transfusion activity and looked at from the viewpoint of stem cell source, types of malignancies for which the patients were transfused or transplanted for. And this data that's presented is just from the bone marrow transplant patients and patients diagnosed with acute leukemia. So they sorted that out, and it represents about 80 patients within that cohort of patients. And what you can see is that there is a lot of transfusion activity, platelet transfusions in the panel on the left of the slide. And that there was variability, significant variability between patients who received stem cell transplant sourced from peripheral blood stem cells as compared to umbilical cord. And this is over a 6-month period. So pretty similar between the two groups, and then as time goes on, as we all know, the cord transplant recipients take a little bit longer to engraft, and so there is a prolonged need for platelet transfusion support. Not as dramatic for red cells, but still the theme is there. Umbilical cord transplant recipients require therapy in terms of transfusion for a longer period of time as compared to peripheral blood stem cell patients, both in intensity as well as numbers. So what I'm going to do is move on now to talk about the risks and then also go into the platelet refractoriness. But I wanted to use a patient, and this is a real patient, to set the platform for you, or use it as a springboard. So this, on a Friday morning, which I think is really important to understand, a 27-year-old female recently diagnosed with AML M5 who was undergoing induction chemotherapy, and she experienced chills and rigors to an apheresis platelet transfusion. We review transfusion reactions every morning as part of daily rounds, so part and parcel of my work clinically. And I just want to pose the question, why do we transfuse platelets? It's somewhat rhetorical. We transfuse in order to improve a patient's hemostatic capacity. And the approach to transfusion can actually take one of two roads, if you will. One is prophylactic, certainly to manage those patients who are experiencing hypoproliferative thrombocytopenia, and the generally accepted platelet transfusion threshold currently is 10,000 per microliter. We also transfuse in the prophylactic setting in the peri-procedural period, and the threshold for that varies widely, anywhere from 10 to 75,000 per microliter. Some folks may go a little higher depending on the type of procedure that's being planned. Or you transfuse therapeutically. You observe that your patient is bleeding and you are concerned because their platelet count is on the lowest side, maybe above 10,000, but less than 50,000 or less than 100,000. So I think they need platelets, and they're issued from the blood bank. So what is the concern about this practice? call the blood bank, they release the product as long as they have it in inventory. But we do need to be cognizant of the risks that are associated with that platelet transfusion. One risk is transfusion acute lung injury. The quoted risk currently is about 1 in 125,000 platelet transfusions. Transfusion-related sepsis, quoted risk currently is about 1 in 107,000. So this is data that's been gathered from a variety of sources and put together. Another risk is hemolytic transfusion reaction secondary to out-of-group platelet transfusions. And by this I mean you have a blood group A patient who may get a group O platelet transfusion. There are some centers that transfuse only ABO compatible, but I would say there's a larger number of centers that cross the ABO when it comes to platelet transfusion. As far as the risk, the data is all over the map, and reviews that have synthesized the data don't provide a specific number for those risks. Other transfusion reactions that, as I'm sure many of you are aware, are the allergic reaction that has a spectrum of presentation. The risk for that is about 1 in 14 platelet transfusions. We get reports for a single hive that a patient may present with following transfusion or during the transfusion, which is okay because we want to hear about those concerns with respect to transfusion. And then FNH, which is febrile non-hemolytic transfusion, occurs at about a rate of 1 in 50,000 transfusions. And as was brought up in the session, I think it was Dr. Giroux mentioned that FNH can in fact be a marker of HLA sensitization and HLA refractoriness. So just to tuck that information away. So looking at TRALI, the clinical picture with respect to timeline of presentation, generally, or in greater than 90% of the cases, patients will present clinically within 1 to 2 hours following the transfusion, and certainly within 6 hours. So if we get a report of a transfusion reaction concern for TRALI and it's the day after the transfusion event, we pretty much say TRALI is not what caused the problem. Let's take another look at what's going on. Implicated products are all comers, plasma being more highly associated than platelets and red cells. And in terms of other clinical findings, hypotension that doesn't respond to fluid, RALs and diminished breath sounds throughout all lung fields, and profound hypoxemia. And this is really one of the hallmarks, an O2 sat that's less than 90%, or a PaO2 over FiO2 of less than 300 millimeters of mercury. The other important thing is to recognize that TRALI, classic TRALI, won't have evidence for fluid overload. But I will say that there often is the combination there, so it is hard to sort it out. And when we evaluate, look for signs and evidence of fluid overload. In terms of what is driving this event, it certainly appears to be an antibody-mediated process in which patients through the blood component transfusion are passively transfused HLA antibody or granulocyte antibody that in the right recipient interacts with the antigens present on the white cells. And the pulmonary bed appears to be a vulnerable organ, if you will, for the bad things that happen as a result of this interaction and release of a variety of cytokines and other mediators. And basically these patients develop a capillary leak-like syndrome. The data that has now really come into play to support this hypothesis was generated through the National Heart-Lung Blood Institute study known as the LAPS-1 trial. And what the investigators did here was to actually set up a prospective study in which they evaluated 7,900 donors. They tipped the evaluation more towards females and evaluated 5,700 females and 2,200 males. And these donors were evaluated both for the presence of HLA antibodies as well as neutrophil antibodies. And at the same time, detailed transfusion and pregnancy history was assessed. And what they found was that HLA antibody prevalence was about 1% in that male donor population and 17.3%, obviously significantly higher, in the female donor population, and that the level of HLA sensitization increased with the number of pregnancies during a woman's lifetime. They then followed on with the LAPS-2 trial, where they followed the donor units provided by these donors and evaluated the recipients. And what is evident here is that the donor units that contain HLA antibodies were significantly more likely to cause TRALI, or the recipients had evidence for TRALI, as compared to donors without donor units without HLA antibodies. And when a definition of TRALI was broadened to TRALI or possible TRALI, you can see this evidence for HLA and antigranulocyte antibody being a mediator was significantly increased. So this has led AABB as well as other organizations to really look at how can we mitigate the occurrence of TRALI. And what has now come to pass is that all blood products, including apheresis platelets, the drop-dead date being October 1, 2016, will be absent of HLA antibodies. So male donors, fine. Never pregnant female donors, fine, can come into the donor pool. A female donor who provides a history of pregnancy has to be evaluated for evidence of HLA antibody, and if it's present, then they are deferred as donors. Now, moving on to transfusion-associated sepsis, certainly the source of bacteria in platelet products, just to remind you all, these are stored at room temperature for up to 5 days. Include the donor. We try really hard to clean the site, but when those 18-gauge needles go into the arm, a little bit of skin can be cored out, or the donor may have asymptomatic bacteremia that lands in the blood component. Also, breaches in manufacturing process have contributed to contaminated units. Implicated organisms, not surprisingly for platelet products, are skin commensals, so Staph coag neg, Propionibacter, and Staph aureus have been reported. And this is a case report from Oklahoma, of a very interesting salmonella case. So an unusual organism, but just to show it can happen. Again, we have worked hard in the transfusion community, I should say, to reduce the risk for transfusion-associated sepsis, and largely through increased awareness, which you can see these are mean annual number of deaths reported to the FDA, a very passive system. And just increasing the awareness promptly led to an increase in reporting to the FDA of transfusion-associated deaths. And on the right-hand side of this is similar data for platelet apheresis products. This bump in both areas led to the decision to culture platelets, apheresis platelets, prior to release to the transfusion service. And this ended up really resulting in a good effect with decreased reports to the FDA. Once again, AABB looked for opportunities to further mitigate this risk, and I'm not going to read through this, but I do want to just point out this last point. It's really incumbent on all of us to optimize the appropriate transfusion practice for all platelet components. In short, transfuse when you need, don't transfuse when you don't need to. So let's come back to our case. So we were sitting at rounds. We took a quick look at the transfusion, saw the yellow here indicate transfusion of components. So in here you can see she's experiencing what we feel are good increments, and then all of a sudden she gets 2 in a row and no increments. She's sitting at 5,000 per microliter. So in short, patient hyperproliferative thrombocytopenia, platelet increment ×2, not great. Clinically, evidence of mucositis with oropharyngeal bleeding. We had a history that she had HLA antibody, PRA stands for panel reactive antibody, and we'll talk a little bit about that in a sec, of 35%. So kind of on the cusp for worrisome, but we were concerned that possibly she was refractory to platelet transfusion. So we said, let's hold tight, let's see what happens over the course of the day. So how do we diagnose or advise on diagnosing platelet refractoriness? What we first want to do and encourage you all who are at the bedside with the patient is to really understand what could be negatively impacting appropriate platelet increments. And clearly, there are non-immune causes which account for about 80% of poor platelet increments or platelet refractoriness, and these include splenomegaly, drugs, sepsis, big time, fever, and consumption. So our patient has clinical evidence for bleeding, so perhaps those poor bumps were due to the fact that she was bleeding. Immune is about 20%, and of these immune, 80 to 90% are due to HLA antibodies to the class 1 antigen A, B, and C. And who's at risk? Goes without saying, any patient who has had a history of pregnancy, any patient who's had a history of transfusion or multiple transfusions. We typically see our myelodysplastic patients get into trouble because they have a very long history of being transfusion dependent. And then any patient who has undergone transplant with a consequent need for transfusion. How do we diagnose it? Well, there is the way just simply to look at how well their platelet counts bump following transfusion. Generally, you hope to see about a 30,000 increase in platelet transfusion. I will say in the hem-onc bone marrow transplant patients, if we see 10 to 15, that's a good day. Or you can do the math and actually determine a corrected count increment. And many of the clinical trials use this to evaluate patients. We don't necessarily have all of the data to allow for this, but basically what it is, you look at the pre and the post and the amount that you gave and into how big of a patient. So you take into account the body surface area. And an acceptable CCI is about 7,500 platelets per meter squared per microliter. The other tool that we have is to actually evaluate for presence of HLA allo antibody. And as Lisa pointed out, there are many different ways to do this. Cell-based, the old days, this is what I did when I was a resident. It's passé now. And then we can use flow cytometry and also solid-phase technology, ELISA or Luminex. And the information that is presented is the panel reactive antibody, a percentage. So this is really telling you how many HLA antibodies are present in a patient's plasma. We're also able to actually identify specificity as well as relative strength of the antibody. So just to go through this quickly, this is what I would call passé method, maybe. The CDC method, patient plasma incubated with the target test cell. If there is an antigen-antibody match, you see this interaction here, add some complement, and then the complement promotes cell lysis and cell death. And so on the left side of this panel are cells that are healthy. They exclude the indicator dye, and on the right, these are cells that, because of the membrane being destroyed, will take up the dye and have cell death. Luminex testing is really the same concept, a little spiffier though. In this case, the HLA molecule is actually fixed on a solid phase bead. You add the patient's plasma, which has HLA antibody, and again, if the antibody is directed to one of the antigens on the bead, you'll have them come together and you add an indicator and it fluoresces. And this is the type of result that we can see. This is an example of a patient who is highly sensitized. So what you can see is a lot of red These are the various HLA antigens across the board, so there's a lot here, and pretty high signal, just indicated by the height of the bar. So how do we manage? Well, first of all, what we don't do is transfuse. If your patient's refractory, you need to start looking to understand what the etiology of that refractoriness is. Not only does continuous transfusion put them at risk for something really bad happening, transfusion reaction-wise, but it also provides more antigen and just stimulates antibody formation. Possibly helpful, short-term might be ABO-compatible platelets, so maybe some of the passive anti-B or anti-A being transfused is impacting in a negative way on the platelet increment. And you can use immune suppression, although there's not a lot of support for doing this. What we feel is a best approach is the provision of HLA-compatible products. So they could be specifically HLA matched for class 1 across all antigens. If there is specificity, you can identify products that are negative for that particular antigen. Or another tool, if you will, in our toolkit is cross-match platelets, where you take the patient's plasma, react it with the donor platelets, and if they don't agglutinate or clump, then you can say, okay, it looks to be a cross-match compatible product. Just to remind you of wearing my transfusion medicine hat, we'll get calls from the floor, I need HLA platelets, my patient's refractory. I just want to let you all know that most centers don't have these on the shelf. It takes coordination between the blood donor center and the transfusion service to make these available. To boot, what you need is both the HLA type of the patient and evidence for HLA antibody. And so we strongly recommend, when we get those calls, send the specimens in and we'll do the testing. And my last bullet on this slide is just to say this is where partnering with your transfusion service, just like folks are partnering with Lisa to find the most compatible donor, or Jerry to really understand, has my patient relapsed or not? We're here to support you as you manage these patients. And so this is really one of our bread and butter activities. So I'm just putting a plug in for that. So coming back to our patient. So this is Friday afternoon. She got a couple more platelets, didn't do well. We saw that she had specificity on the HLA antibody screen. Unfortunately, we didn't have an HLA type, so we resorted to calling our blood supplier saying, give us antigen X negative platelets and we'll see how she does with those. Saturday call-in review. So this is a patient we were really monitoring closely. She unfortunately continued to have poor increments and lo and behold had another reaction to an antigen negative unit. So the resident on call made the recommendation for cross-match platelets, advised them to not transfuse unless they really needed to, and also the consideration for adding Amicar as it's an antifibrinolytic for clot stabilization. So I come in on Monday and look at her history, and this is what you see. She got many more platelets, and I think I have it here, 10 platelets, absent increments, and over the course of time, 3 of those platelet transfusions were associated with a pretty significant Chill-Riger reaction. So Monday morning, we called to the floor and we said, let's hold on any additional platelet transfusions until we can get an HLA matched in, because by that time we had her HLA type. And we also recommended the continuation with Amicar. So she got transfused an HLA match product, and this is a rare observation, but she bumped up to 60,000. A great donor. We want that donor to be assigned to this patient. But the question is this really success at last? Yep, we got a nice bump, but this woman had gone through multiple transfusions, no benefit from those transfusions, and if anything, untoward impact of the transfusions with the transfusion reactions. So this raises the question of whether or not prophylactic platelet transfusion incurs an unnecessary risk. And there are a number of publications, and I just selected the Want et al. Publication, where investigators are wondering whether or not you can manage patients through simply therapeutic platelet transfusion as opposed to prophylactic. So this was a randomized control trial published back in 2012, and there's been another one by Simon Stanworth et al. Out of the UK. Primary endpoint, number of platelet transfusions. Secondary endpoint, clinically relevant bleeding. And I'm just going to speed through here quickly. So in terms of the primary outcome, what you can see, not surprisingly, that there were clinically or statistically significant fewer platelet transfusions in those managed by the therapeutic protocol as opposed to the prophylactic. Similar in the subgroups of AML as well as autologous. Now, in terms of the secondary outcome, bleeding, what you can see, grade 2 bleeding runs the gamut, as many of you know, to very little bleeding, to a little more significant hematuria, maybe oropharyngeal bleeding, not requiring transfusion. Not surprisingly, the therapeutic group had statistically significantly more bleeding than the prophylactic group. No difference between the two groups for grade 3 bleeding. And in the autologous arm, there was no evidence for grade 4 bleeding, but unfortunately in the therapeutic group in the AML, 13 grade 4 bleeds compared to 4. Now there's some nuances of the protocol that suggest maybe in this arm, because they weren't being screened as in the same manner, that this contributed to it. So this led these authors to conclude that a therapeutic strategy may be okay for patients with autologous transplant in the autologous transplant setting, but that it is probably prudent to continue with prophylactic platelet transfusion management in patients undergoing therapy who have AML or the acute leukemics. And then I came across, as I was putting these slides together, this what I think is a great editorial by Charlie Schiffer, published in late 2014. This is my own title. Wait, it's not about a number, but the editorial basically is commenting on the studies looking at prophylactic versus therapeutic. And what he points out in this editorial is that, yes, there are clear differences between patients who are undergoing autologous stem cell transplant versus those patients that are undergoing allo or high-dose chemotherapy for a heme malignancy. And not only that, there are differences in age, comorbidities, and in our autologous patient population, those white counts and platelets bump right up. But unfortunately, in some of our heme malignancy patients, it's protracted. So they're at a higher risk potentially for bleeding for a much longer time. The other thing that he points out and encourages folks to start looking at is that, in fact, we saw 13 and 4, that of all these patients, so few patients actually experience these catastrophic bleedings. And when you dive deep, in fact, these bleeds occur at very high platelet counts. So I'm just going to close here. He also suggests that we should be looking at what is special about those patients who bleed and have these devastating bleeds. And then he reminds at the end of his editorial, it really is management of these patients is really, the hallmark of the art of medicine. You need to look at your patients and individualize care. So I'm just going to skim through this one real quick and say thank you. This is not what Boston looks like today. It's a nice summer evening. So thank you again.